do is have, at the end of the trial, the company might like to have long-term follow-up where everybody gets the medication, and then they just keep looking at safety and efficacy. It's no longer blinded because everybody's getting the medication, so sometimes they do that. I mean, if they find that the treatment didn't really work too well, the patients would just go back to regular office visits. So it kind of depends on the design of the trial, but a lot of them do tend to have, typical lupus trial would be like 6 months or probably more of a year, and then they would have longer term follow-up. Because, you know, lupus is diseases that kind of goes up and down, and it'll tend to flare over time without treatment. And so they would want to see, does this treatment in this, you know, open, what we call open label follow-up, does it continue to control the disease well? And also, are there any side effects?
And then potentially, once the trial's over, if there's an approval, then you roll out of the trial and get the drug.
Yeah.
And that has happened, but this, if you're really, really lucky.
That was going to be my next question. If I complete the trial, am I guaranteed the medication afterwards? No, not necessarily.
Yeah.
Okay, just a couple more questions, then we'll open it up to the audience. To the two doctors, as you're seeing patients, when would you kind of approach them about a clinical trial? Is that something you do in, you know, your normal office visits, or Dr. Brand, like you were saying, when you receive this information, do you then say, okay, this specific patient, I want to talk to them about this? How do you kind of approach your patients regarding clinical trials?
Well, when I get this information, I usually don't think about specific patients. I just look at the practice and decide, like, is this a trial that we're going to even recruit people for? Is it too difficult? But then once we've decided we're going to participate, you have to go through a lot of steps, get your IRB approval, make sure all your personnel in place, and then the company has to do a couple visits. Sometimes it's virtual, but they have to make sure that all the basics are there in order to complete the trial. With Temple, they're not the quickest in the world, so sometimes it takes a year to get all this stuff in place. That's not me, that's Temple. So, and then as you would see patients, you know, you would, I think that's kind of how I do it. I wouldn't be able to just think of people off the top of my head, but as you're seeing a patient, you would say, oh, their prednisone level's too high, so they wouldn't, or they have certain amount of damage already, so I wouldn't, you know, this patient's pretty good. But the first thing I do is, you know, one, would they be able to understand what I'm discussing with them? So sometimes if they don't speak English, now we have a bunch of Spanish-speaking doctors, so that makes it a little bit easier because they can explain the trial in Spanish. But if they were speaking another language like Arabic, I probably wouldn't approach them. I think I would never be sure that they understood everything, even with an interpreter. But with a live physician, I feel like I could, you know, ask the questions I need to ask. But I would look like, do they meet the criteria? You know, the other thing I look, do they tend to come to their appointments? If I have someone that comes like every 2 years, I'm probably not going to ask them about a trial because you don't want to have someone that's not going to show up for the visits.
Yeah, no, I agree. It's usually somebody who's not doing very well on their standard of care treatment. And usually as part of shared decision making, I'll make a sort of, the next step looks like it could be A, B, C, or D, and D might be a trial. And if they are interested in hearing more about the trials, I actually will often have one of my fellows come in and explain the trial to them, because I really don't want to force somebody to think they have to do a trial, but more to understand that that's in the option of different things that we talk about. And then after that, if they're interested in a trial, then we'll go into more depth about it. But I think it has to be a shared decision-making process.
So this is going to be the last question.
So the other thing I tell them is, whether or not you participate in the trial doesn't make any difference to me. So if you decide you don't want to do it, then I'm just going to, you know, our relationship's going to be exactly the same. So I don't try to put any pressure or anything. I just say, if you don't want to do it, that's cool.
So what is kind of your message to this group regarding clinical trials? Those who are kind of hesitant or just are kind of like, nope, I'm not interested in that whatsoever. What would your final piece of kind of advice be regarding clinical trial participation?
I mean, if somebody has heard about, has the trials explained to them and they're not interested, that's great. It's not a big issue. We're going to take care of you with plan A, B, or C. So it's really, there's no coercion involved. There's no sense of, oh, you have to do this. That's really not, you can't do that anymore.
I mean, as an example, in years past, I've had patients with not lupus, but other rheumatic diseases, and they were not doing well at all on therapy, and I actually sent a couple patients with scleroderma to Johns Hopkins because they knew they had a big scleroderma center. I said, maybe they'll have a trial that you can participate in because there's nothing more I can do. So I've done that. If I had someone with really bad skin disease, I would send them to Dr. Worth because I know she's doing, I mean, I would find out what trials, but I would certainly send them there because we're not doing those trials.
Nikki, what about